And now it's been a long journey, but we finally arrived at the top of the pyramid, the apex of the triangle, and we're talking about intervention studies. So I've put a bunch of different terminology here so you can recognize when you are reading about or hearing about a randomized controlled trial or intervention study. So you can hear randomized trial, clinical trial, intervention study, experimental trial, or just trial. So trial, experiment, intervention, those are the kinds of terms that are unique to this type of study design. So as usual, we start with a defined study population, and this means that we have particular eligibility criteria by which we decide whether someone is eligible for our study or not. I don't think I've mentioned that before. And those criteria are established just to assure the validity of the study, and they depend on the particular study. But certainly for a cohort or a randomized controlled trial, one of the criteria would be that the people do not have, do not have the outcome. So they don't have any sign of the disease that's the outcome that the study is looking at. And so really the defining characteristic of the randomized controlled trial is the randomization process. So people in the study population are randomized into the exposed versus the unexposed groups. And then once they're put into their groups, the exposed group is obviously exposed to the intervention. So there's usually an intervention group, you could call it, versus a control group. And obviously the intervention varies with the study, and so does the control group. And then participants are followed to see who develops the disease and who doesn't in both groups. And so this design is almost the same as a cohort study, but with a very, very important difference, which is that that there's an intervention. Okay, so the exposure in the case of a randomized control trial is an intervention, and the groups are randomized. But otherwise, the design is similar. So the outcomes that you get in a randomized controlled trial also, this trial will give you, this design will give you incidence data as well. And so, but the reason that it's so at the top of the pyramid is because it provides the best evidence for causality, because it eliminates problems with confounding, or ideally, it decreases problems with confounding. Okay, so now I'm going to tell you about an example of a great randomized control trial. And so this is called the Diabetes Prevention Program, and this is pretty well known. And so the question being addressed in this study was whether diabetes can be prevented by changes to lifestyle. And so the way the study worked is they enrolled 3,234 people who were at high risk for diabetes, and these are adults. So these people had to have pre-diabetes, which is elevated blood glucose. And the reason for that is because they wanted to be sure they had enough cases of diabetes develop to be able to measure the effect of the intervention. So if nobody developed diabetes across any of the arms of the study, then they wouldn't be able to tell the difference. So, and then of course they were randomized, the sample was randomized, and then they were randomized into one of three groups. And so we have the lifestyle intervention, which is where they were trained by lifestyle coaches. It was very intensive, to lose weight and increase their physical activity. And then another group was given metformin, and another group was given a placebo, and this is the control group. So here you can see, you can test multiple arms. And then the researchers followed up the participants for 2 to 5 years, depending on when the participant was enrolled in the study, to see whether they developed diabetes. So this graph shows the results of the Diabetes Prevention Program study by arm. So this shows the incidence of diabetes in each of the study arms. So you can see here the lifestyle group had the lowest incidence of diabetes, even relative to the metformin group. So we can calculate the relative risk reduction in the lifestyle and the metformin group. So remember that relative risk reduction is 1 minus relative risk. And so let's calculate the relative risk. So we have the incidence in the lifestyle group is 5%, so it's 0.05. This group, metformin, 0.078. And in this group, it's 0.11. So the relative risk for lifestyle group equals exposed, incidence in exposed over incidence in unexposed, equals 0.45. And then, so relative risk reduction equals 1 minus 0.45 or 0.55 or 55%. So the people who engaged in this lifestyle changes reduced their risk of developing diabetes by 55%. And we can do the same thing for metformin. So hopefully you tried it yourself, but the relative risk, here it is for the metformin group. So 0.78 exposed over unexposed, and so on. So that comes out to 29% risk reduction. And we can also look at number needed to treat. And here's the formula for that, 1 over absolute risk reduction. And this tells us how many people we have to treat in order to reduce diabetes by 1, or eliminate 1 case of diabetes. So let's calculate that for the lifestyle group and then the metformin group. Okay, so here's the calculation of number needed to treat for the lifestyle group. So we have the unexposed 1 over the absolute risk reduction, which is the unexposed risk and unexposed minus risk and exposed, and that whole thing comes out to 16.7. So this means that you have to treat 16.7 people with the lifestyle intervention treatment in order to prevent 1 case of diabetes. And then the same thing is on the bottom. And by the way, I realized over here, calculating relative risk, I had a typo. So I had 0.78 instead of 0.078, so I changed it there. But anyway, so then this number needed to treat comes out to 31.25. So that's another way of looking at the difference between treatments, and you can do that because these are in the same study, so it's legitimate to compare numbers needed to treat. You cannot do that across studies, as you know. But anyway, so this shows you need almost twice as many people to treat almost twice as many people with metformin as you do with the lifestyle treatment in order to prevent 1 case of diabetes. So there are a few things that are really important to understand about intervention studies and that are unique to intervention studies. And 2 of them are randomization and blinding. And then the other one is loss to follow-up, which I'm going to talk about in the next video. So randomization, what's the purpose? One is to prevent selection bias among the investigators. So if you have a patient and you know that you think your drug is going to work to help the patient, and you like your patient, you might like certain patients better than others, and so you might put them into the treatment group instead of the placebo group, thus biasing the study. So so randomization prevents the investigator, or anyone else for that matter, from deciding based on some perhaps confounding characteristic who gets to be in the study. So so that's one thing. And then the second thing is something we've already talked about, which is it makes the groups comparable with regard to characteristics that might affect the outcome. So with a cohort study, for example, you wouldn't be randomizing people. You would just take people who happen to be thin and exercise a lot, let's just say, versus people who didn't, maybe in a control group. But there would be a lot of other factors that would be related. So probably income would be related, etc. And so that's the problem with a cohort study, is there's all these confounding variables that emerge because of the way life is and the way certain people tend to do certain things because of other things, and so characteristics tend to cluster together. But with an RCT, you eliminate that, and moreover, you eliminate confounding factors that you're not even aware of. So we've talked about that a little before, but those are two things to remember. And the other thing that's critical is blinding. So as I just said, randomization helps blind staff, at least to the distribution or allocation of participants to groups, but all throughout the study, the staff have to be blind to the assignment, particularly people who are assessing the outcomes. So that's really important. And, in the case of the metformin and placebo arms in this trial, the study staff who distributed the medication were probably blind. And the participants were blind, and so that's the point of a placebo effect. Now, with a behavioral intervention such as this, it's impossible for the intervention staff and also the participant to be blind, because they know, obviously, that they're in this condition. So that's a limitation of a behavioral trial. But blinding is important, and randomization is important in the RCT.